to the left is Ryan, Tiffany, Matt, Cole, and Ross. And the title of our study is adductor canal block versus adductor canal block with local anesthetic Exparel following a unilateral total knee arthroplasty. And we're going to be presenting the preliminary results today. So just a little introduction to why our study is important is there's a recent significant increase in TKA procedures that are being performed. It's projected to grow to 673% by 2030, which is pretty significant. The average cost per procedure is roughly around $31,000, and with the increase in TKA procedures being performed, there's also a decrease in reimbursement rates. So that's significant for us. So with the trends of increase in TKA procedures, with the reduction in reimbursements, it's important for healthcare organizations now to develop cost-effective ways to implement their treatment without compromising patient care and safety. So, a little introduction to the anatomy. So, the adductor canal stands from the middle thigh, begins at the apex of the femoral triangle, and it goes down to the opening of the adductor magnus muscle. Okay, and it's bordered anteriorly by the sartorius, posterior medially by the adductor longus magnus, and medially by the vastus medialis. It houses the femoral artery and vein, saphenous nerve, and femoral nerve branch that's going to travel to the vastus medialis. So, like I said, physicians are now implementing these adductor canal blocks for post-operative pain control. But in addition to that, it's important that it also spares early quadricep muscle activation, and that's important for us and the patient. Okay. So, just a little information on what Exparel is. It's a local anesthetic. Okay, it's a long-lasting local anesthetic. And this is for post-operative pain control. It's administered with a single dose into the posterior capsule, and when it's into the posterior capsule, it's distributed to 3 different locations. Okay, and average cost is roughly around $285 per 20 mLs. Okay, so our question is whether or not it's justifiable to implement the Exparel with the adductor canal block for each patient episode of care, and we'll find that out based on the outcome measures, which we'll get into.
So the justification for our study, there's little evidence to determine whether or not adductor canal blocks alone are superior to adductor canal blocks with that local anesthetic Exparel. And in regards to total cost, length of stay, and total ambulation distance, if the results of the study indicate that the use of Exparel has a positive correlation in the specific outcome measures listed above, then the cost of adding Exparel would be justified in the TKA procedures. So the purpose of our study is to determine the effectiveness of the adductor canal block when compared to the adductor canal block with Exparel in patients with unilateral TKAs in regards to hospital length of stay, cost, total ambulation distance, TUG score, and then pain levels, and we'll go over those a little later too. Our hypothesis, it was hypothesized that participants who received the adductor canal block with Exparel would have significantly shorter length of stay, decreased hospital cost, increased ambulation distance, decreased TUG score, and a decreased pain score.
So our research design is a randomized controlled trial. However, right now, all of our subjects have been randomly put into group A. So, and we're blinded to what group that is. We don't know at this time if they are in the control or experimental group. And our independent variable is set at 2 levels, so they will get the adductor canal block with the drug combination, which will be explained later by Cole, or the experimental group, which is the adductor canal block with the drug combination and Exparel, the local anesthetic. And our dependent variables include length of stay in the hospital, total cost, maximum ambulation distance, timed up and go score, and our secondary outcome is pain levels through VAS. For our methods, we were approved by the Institutional Review Board of both University of Mary and CHI St. Alexius Hospital, and the research participants have been selected through the attending orthopedic surgeon, which is Dr. Timothy Bopp, the physician assistant, which is Colleen Stalick, and the total joint coordinator, which is Mark Johnson. This selection process is really important because CHI St. Alexius is one of the first hospitals to be selected for the bundled payment system for insurance. And this, they're given a certain amount of money for the entire episode of care. So it's really important that the candidates are screened to be good candidates for the specific surgery. For our inclusion criteria, we accepted male and female participants between the ages of 18 and 85 that were receiving a unilateral or one-sided total knee arthroplasty. The reason for the total knee needed to be a non-traumatic origin, so it was secondary to either osteoarthritis, degenerative joint disease, or other knee dysfunctions that cause pain and limited knee range of motion and functional ability. All subjects were prepped, screened, and deemed appropriate for surgery. And prior to surgery, they signed the consent form and also the St. Alexius intake form. And our exclusion criteria included a BMI of greater than 35, which would put them outside of the obesity stage 2 category. Any events that would disrupt, prevent, or contraindicate physical therapy, including hemoglobin, hematocrit, nausea and vomiting, or anything that would prevent participation in physical therapy. If they had neurological disorders that would potentially impede their progress, if they had undergone a bilateral total knee, they were not able to participate in the study. If they had any hypersensitivity or were unable to follow the St. Alexius rehabilitation protocol, they were excluded from the study.
And so because of the extent of the surgery and whatnot, we wanted to implement stopping rules, and we didn't utilize these as these are preliminary results, but for future study, the stopping rules basically look at safety effectiveness of the research trial, any new information that comes along the research project, and then a detectable minimal change in the outcome measures, just to make sure the patients are safe and optimize safety. Outcome measures were obtained through medical records and hospital records. So the tug is the total time it takes for the participant to rise up from a chair, walk 3 meters at a comfortable pace, with or without an assisted device, and then turn around and sit down. A length of stay was defined as discharge from physical therapy based on discharge protocols from physical therapists. And then total hospital cost was defined as the overall cost of the hospital, including the surgery, opioid use, room and board, other skilled services of healthcare professionals. Taking that all into account, total ambulation distance was defined as the maximum distance a patient ambulated either using or not using an assisted device. And then we use a secondary outcome measure as pain. We put that as a secondary outcome measure due to the subjectivity of pain, and we really wanted to use more objective measures for our study, but we also included the visual analog scale.
Alright, so during the total knee arthroplasty procedure, the orthopedic surgeon injected a combination of Exparel, bupivacaine with epinephrine, Toradol, as well as morphine, and that was for the treatment group. The control group had the exact same combination of drugs, except without Exparel. The injection was intra-articular through the posterior capsule of the knee, and it was redirected throughout 3 different locations within the joint. And then a post-operative tug score was performed by the supervising PT on the second visit of post-op day 1. So through our calculations and our outcome measures, we determined that 64 patients were needed for the study. Then due to the extensive planning process and the approval through IRB, we were able to recruit 3 subjects for the study. And 2 were excluded, and that was due to the fact that they didn't meet the exclusion criteria. And we are currently unaware of whether Group A or Group B received the Exparel, as we have been blinded to the study.
Okay, so included is a chart of the 3 subjects that were included into the study. As you can see, the column or the rows of subject 1, 2, and 3, the columns patient demographics, and then the outcome measures. You can see a possible link between tug score and pain. As you can see, 30 seconds compared to an afternoon pain of 4, and then subject 2, 17 seconds tug, and then pain scale of 0. I had the opportunity to be at CHI St. A's and work with these patients, so I had in with these guys. So results, you can see the mean age, mean tug score, and mean BMI. At this point, no correlations can be drawn since all the subjects were in the same group. And with us being blinded, we don't know if they're in the experimental or control group. So clinical implications, it's important to identify the effectiveness of EXPAREL in order to improve patient outcomes and decrease risk of complications at the acute care and the outpatient settings. So increased BMI will result in increased complications after surgery, increased tug score, could be an increased fall risk, and then all these aspects are important because of the bundled payment under the DRG. So in conclusion, additional subjects are required, and then we'll reach 128 until we reach 128 subjects. And it's been a great learning opportunity in order to complete the IRB approval process and collect the data with the assistance of Dr. Parker. And we hope statistical significance is found as the study continues. We would like to thank Dr. Parker, Dr. Bopp, and Colleen Stalock, and Mark Johnson for their time and effort so far. Any questions for us? Sorry I had to rush that.
Is there somebody up front for that? Yeah. Ross, I was going to ask you, could you kind of describe for us when the tug measurements were taken, day one post-op, just so people can get a feel for that, and not to put you all on the spot, but just how those tug measurements compare to, just in general, how the tug measurements in recording.
Right. And so a typical post-op day one, what I would do is with these three subjects is in the morning I would usually do exercises, take them for a walk, and then in the afternoon I'd like to do maximum ambulation distance and then complete the tug with them. If I were to overdo it in the morning, there was, for example, there was subject one had an increase in pain in the afternoon, and so that would probably have an adverse effect on that. And so I communicated with the PTs moving forward at CHI St. A's to try to implement the tug during post-op day one in the afternoon session in comparison to the morning. So,
how many tug trials did you do? You told me this.
Right. What I would do, I'd do a minimum of at least two tug trials, and if I saw a significant difference in, say, like 5 seconds or so, I'd encourage them to complete a third. Obviously their post-op day one, a total knee, they might not be completely motivated to complete a third trial, but it was nice to see the improvement from the first trial to the second trial and possibly a third trial as well. So we took the average, or the best score out of the three trials for the time. Okay.
What was your discharge requirements then? I mean, was it independent with everything, or in assist with a caregiver, and how would that vary with your study?
Right. At CHI, what they required is that it's an elective surgery, and so they were not required but suggested to have a coach, and so they could go home at the min-assist level, having min-assist for transfers and functional mobility and with stairs as well. So that would be discharged to be able to complete their exercises, ambulate with a front wheel walker safely, and be able to do the stairs if they have them at home. Parker, yeah?
You had to exclude one of the patients. What was the, I know you know the answer to this question, but I think what was the BMI? It was a problem with BMI, right?
Yes, yeah. I went through and collected data for this patient, and our exclusion criteria is BMI greater than 35, and she had BMI of 37, and so it's a possibility, it's something that we would change possibly going forward, is maybe increasing that exclusion criteria to greater than 40 instead of 35 in order to include more patients.
Now, is that, the reason I bring that up is that in the CHI comprehensive drug replacement program, they will not, surgery family will not operate on somebody with a BMI greater than 40. What is it? Is it 40 or 35?
I didn't talk to Mark about it, but yeah.
We were actually below.
my criteria up to it so it aligns with maybe